We will start speaking about hematological disorder in pregnancy and their management. As you know, it includes sickle cell anemia, thalassemia, and anemia in pregnancy. We will start today with sickle cell disease in pregnancy. A bit of introduction about sickle cell disease. Sickle cell disorders is a group of inherited single gene autosomal recessive disorder which is caused by a sickle gene which affects the hemoglobin structure, and it's classified into sickle cell anemia where there is a homozygous affection of both genes, so the structure will be HBSS, and the heterozygous conditions, which is a combination of hemoglobin S and other clinically abnormal hemoglobin, which can be include combination with hemoglobin C or combination with beta thalassemia, combination with hemoglobin D, E or O Arab. All of these genotypes will give similar clinical phenotype of varying severity. We have two main groups. The group which is sickle cell anemia or sickle cell disease, which is homozygous for hemoglobin S, and the group which are sickle cell trait, which is a mild type, and they are heterozygous for hemoglobin S. Sickle cell trait usually present with urinary tract infection in pregnancy, which is the most common complication for sickle cell trait, and usually it's of mild type and well controlled throughout pregnancy, and in most situations there is no need for any specific intervention in the management of sickle cell trait, but sickle cell disease, which is our topic today, and we'll go in details in it. So to start with, sickle cell trait, as we said before, it is a mild type where there is hemoglobin S combined with normal hemoglobin A, usually asymptomatic, and increased risk of urinary tract infection and microscopic hematuria, and there is no need for specific intervention during pregnancy. Complications of sickle cell disease. These complications result from the abnormal shape of hemoglobin S, especially under hypoxic states, where this hemoglobin S carrying red blood cells will aggregate and cause occlusion of the blood vessels. This can result in stroke, pulmonary hypertension, renal dysfunction, retinal disease, leg ulcers, cholestasis, and avascular necrosis of head of femur. Fetal risk. Due to the vascular nature of these complications, it can lead to miscarriage, intrauterine growth restriction, or small for gestational age. 21% of neonates born to women of sickle cell disease are below the 10th centile. That's why sickle cell disease is an indication for serial growth scan from 24 weeks, stillbirth about 1%, preterm delivery about 27%, increased perinatal mortality 6 times, but there is no risk of fetal hemoglobinopathy. Maternal risk for sickle cell disease. Complications of sickle cell disease are more common in pregnancy, and the crisis can occur up to 35%. Because the crises of sickle cell in general are more common in hypoxic states, and because pregnancy is characterized by increased rise to oxygen and hypoxia is more easily developed, also sickle cell disease complications are more common with dehydration, and the pregnancy is more liable for dehydration due to persistent nausea and vomiting, especially in the first trimester. So these women are at risk of acute anemic crisis, which is due to sequestration of the red blood cells, most likely due to infection by a virus called erythrovirus. Risk of preeclampsia is increased. Risk of venous thromboembolism is increased due to the nature of hemoglobin S, increased sticky nature of the blood, increased risk of bone marrow embolism, increased risk of sepsis, UTI, pyelonephritis, pneumonia, and behavioral sepsis. That's why women who are sickle cell disease and feel unwell should be taken seriously and cautiously, and all these risks must be excluded before attributing to anything else, because are serious risks and have serious consequences if not treated promptly. Investigation required for women with sickle cell disease: for blood count, vitamin B12, folate, and serum ferritin to predict the iron overload, liver and kidney function test, red cell antibody, urine dipstick for proteinuria, retinal screening for proliferative retinopathy, screen for pulmonary hypertension, screen for iron overload. As you know, women with sickle cell disease, if they are in continuous blood transfusion, they are at risk of iron overload. And as you all know, iron overload can affect the liver, the heart, the pituitary gland, and the kidney. These women usually are on iron chelating agent before pregnancy, which usually they are stopped at pregnancy because iron chelating agents are teratogenic and should be stopped prior to conception. And this froxamine, which is the safest one, should be stopped for the first 3 months in conception, which increase the risk of iron overload. That's why this one must be screened for iron overload. Hemoglobinopathy of the partner must be assessed to identify the risk of transmission to the newborn and screen for hepatitis B and rubella. These women should be seen preconceptionally and must be assessed for organ dysfunction as a result of sickle cell disease or iron overload. And if there is any organ dysfunction, they must be advised against pregnancy and offered the proper contraception. However, if the disease is well controlled, in these situations we must start the prophylactic measures and preventive measures to ensure a well-controlled disease during pregnancy, like we need to commence penicillin prophylaxis, offer Haemophilus influenza type B and meningococcal Z vaccine. These women are at risk of infection, especially if splenectomy was done in the childhood. Pneumococcal vaccine should be given every 5 years. We have to offer hepatitis B vaccine if not immune. We have to recommend annual influenza and swine flu vaccine and start folic acid 5 mg per day. For antenatal care, these women require multidisciplinary care with joint clinic between the obstetrician and the hematologist with interest of sickle cell disease in pregnancy. Anesthetic assessment must be performed in the third trimester. Screening for end organ damage, renal screening, retinal screening, screen for pulmonary hypertension. All of these must be done during pregnancy as well. Avoid persistent factor of sickle cell crisis like dehydration, lack of sleep, long flights, hypoxic condition, stress, and seek medical advice early in the event of persistent vomiting because vomiting will lead to dehydration and dehydration can lead to sickle cell crisis. Partner testing for hemoglobinopathy if not done preconceptional. Influenza vaccine if not administered in the previous year. Folic acid 5 mg and continue benzoyl which should have been started preconceptional. Review the drugs. Usually this is done preconceptional, but if the woman missed the preconceptional visit and she comes while she's pregnant, again review the drugs she's taking during pregnancy and ensure that these drugs are not teratogenic. Iron supplementation only if iron deficiency. Aspirin 75 mg per day from 12 weeks to reduce the risk of preeclampsia. Prophylactic low molecular weight heparin during antenatal hospital admission. Sickle cell disease is a risk factor for venous thromboembolism. Women should be assessed for other risk factors according to Royal College guideline of venous thromboembolism prophylaxis. We have to send monthly midstream urine analysis for culture and sensitivity. Blood transfusion. Women with sickle cell disease usually are on long-term blood transfusion. However, in pregnancies, there is no rule for prophylactic routine blood transfusion, but there are certain indications for blood transfusion, like if woman had acute anemia, she will require top-up transfusion, or woman with a previous serious medical, obstetric, or fetal, she will need exchange or top-up transfusion. Women who are on transfusion regime before pregnancy or who have twin pregnancy need prophylactic transfusion. Acute anemia will require top-up transfusion. Acute chest syndrome or acute stroke will require exchange transfusion. In case of pregnant woman who is known to be sickle cell disease and present with acute illness, as I said before, you must exclude sickle cell crisis as a matter of urgency. This can be done through a multidisciplinary team approach with involvement of anesthesia, medical registrar, especially if overnight, or hematology with an experience of sickle cell disease preferably. Appropriate analgesia. Precedent shouldn't be used as precedent can exacerbate sickle cell crisis. These women require adequate pain relief. We use WHO analgesic ladder should be used starting with paracetamol. Non-steroidal anti-inflammatory drug can be used for mild to moderate pain between 12 and 28 weeks of gestation. Weak opioids such as codidramol, cocodamol, or dihydrocodeine can be used for moderate pain. Stronger opiates such as morphine can be used for severe pain. Fluids and oxygen because these women are dehydrated. Sickle cell crisis usually exacerbated by dehydration and hypoxia. That's why IV fluids must be given and facial mask oxygen. Thromboprophylaxis because these women are at a high risk of venous thromboembolism and ask for investigation in the form of full blood count, erythrocyte count to look for infection and hemolysis, and kidney function test. Acute chest syndrome. It's the most common complication and most common presentation of sickle cell crisis. It is characterized by respiratory symptoms such as tachypnea, chest pain, cough, shortness of breath, and presence of new infiltrate on chest X-ray. Early recognition of acute chest syndrome is the key for prompt management and avoidance of consequences. And the key for all of that is any woman who presents with who is known to be sickle cell crisis, any woman who is known to be sickle cell disease presenting unwell, we need to have in our mind that acute chest syndrome is a common complication. Treatment: intravenous antibiotics, oxygen and blood transfusion, top-up blood transfusion may be required, ventilatory support may be required. These women are at increased risk of pulmonary embolism, that's why we have to start them on therapeutic low molecular weight heparin. Acute stroke is another complication of sickle cell disease. It can be post-infarctive and hemorrhagic, present with acute neurological impairment. Acute stroke is a medical emergency. Rapid exchange blood transfusion can decrease long-term neurological damage. These women require urgent brain imaging. Thrombolysis is not indicated in acute stroke secondary to sickle cell disease. Why? Because as you can see, acute stroke can be post-infarctive or hemorrhagic. So if you give us thrombolysis for a hemorrhagic stroke, you are actually increasing the risk of bleeding and getting intracranial hemorrhage and increasing the size of a stroke. That's why urgent brain imaging should be done first. Neurological involvement is a must, and multidisciplinary team approach for management of acute stroke in case of acute sickle cell crisis. Acute anemia, usually due to erythrovirus infection. In this case, erythrocyte count should be requested. Treatment is with blood transfusion. Women must be isolated. Vertical transmission of the fetus is known, and this can lead to hydrops fetalis. That's why the fetus will require ultrasound assessment. Anemia owing to bleeding or any other cause of anemia must be excluded as well. So not every acute anemia is erythrovirus, although it is the most common in sickle cell disease women. However, other causes of anemia must be sought and excluded. Rare causes of anemia in sickle cell disease include malaria, occasional splenic sequestration in women with mild phenotype. Intrapartum care. These women need to be offered elective delivery after 38 weeks of gestation in an obstetric unit that is able to manage the complication of sickle cell disease. Sickle cell disease itself is not an indication for the resection. As these women are in long-term blood transfusion, there may be a typical antibody in their blood, and accordingly cross-match is required, and close liaise with the blood bank is essential in women with sickle cell disease. Multidisciplinary approach, including senior midwife, senior obstetrician, anesthetist, and hematologist. Continuous electronic fetal monitoring is required. Women should be kept warm and well hydrated to avoid exacerbation of crisis during labor, as it increases the frequency of sickle cell crisis and acute chest syndrome as a result of the physiological nature of labor. That's why we need to avoid pain, stress, dehydration, and hypoxic conditions. Avoid the use of Pestins is very important. Pestins is not allowed as a pain relief because Pestins exacerbates sickle cell crisis. Regional analgesia is recommended for cesarean section. Postnatal care. Women must be observed for evidence of sickle cell crisis. Again, postnatal period is a period of increased risk of sickle cell crisis due to dehydration, stress, and anxiety. Maintain oxygen saturation above 94%. Adequate hydration is essential. TEDS plus low molecular weight heparin because these women are at risk of venous thromboembolism. Offer contraception. Progesterone only contraceptions are safe and effective. Estrogen and copper should be used as second line agents. Veno-occlusive crisis. In sickle cell disease, microcirculation is obstructed by sickled red blood cell. Ischemic injury to the organ supply can happen. Usually this one present with pain, as is the most frequent complaint. Bones frequently involved, especially the head of femur, will suffer from avascular necrosis. Spleen autoinfarct and autosplenectomy may occur. Liver can also be affected. Renal biliary necrosis. Lung involvement cause acute chest syndrome. CNS involvement causing neurological impairment and skin ulceration. Infectious crisis due to underlying functional asplenia, lower serum immunoglobulin M levels, impaired opsonization. All of these factors lead to increased risk of infection, and infection will lead to sickle cell crisis. Defective immunity against encapsulated organisms, Haemophilus influenza and strep pneumonia. That's why we have to offer vaccination for Haemophilus influenza on a yearly basis, and that's why we need to offer these women benzyl penicillin as a prophylaxis to avoid infection. These women are at increased risk of other common infectious agents, including Mycoplasma pneumonia, Salmonella, Staph, and Escherichia coli. Hematological crisis, sudden exacerbation of anemia, happen due to splenic sequestration or less commonly hepatic sequestration, can be caused due to bone marrow aplasia, also can be caused due to parvovirus infection, folic acid deficiency, or drugs such as phenylbutazone. In general, management of crisis will require a multidisciplinary team, which include obstetrician, anesthetist, neonatologist, and hematologist with experience of sickle cell disease in pregnancy. Severe crisis may require high dependency care. Immediate pain relief is needed using the step-ladder approach, starting with paracetamol, non-steroidal anti-inflammatory drug between 12 and 28-week gestation, opioids, avoid Bisden, maintain adequate hydration, identify and treat any infection, oxygen treatment, blood transfusion may be required either as a top-up or exchange transfusion, continuous electronic fetal monitoring is required in case of crisis. Thank you for listening. If you have any questions or query, please write it in the chat and I will respond to you as soon as possible. This presentation was based on Royal College Guideline on Management of Sickle Cell Disease. Thanks, Mohammed Nasharti.